Thank you, Paul. That's a fantastic presentation, really summarizing, well, first of all, we were treated to an anatomical masterclass, and then, well, some honest surgical cases, really. So I'm very pleased that you showed those and showed that you have difficulty as well, just the same as all of us. I'd like to start the questions, and can I encourage everyone, if you've got questions, please put them in the Q&A, because we can keep track of them there. We can't keep track of them in the chat. They get lost in there. So if you have some questions, pop them in the Q&A. Your sort of classification of problem patients, Paul, it included patients with diabetes. Do you have any evidence that patients with diabetes do worse than kind of equivalent patients who don't have diabetes?
Well, in my hands, they seem to do. So maybe I do something wrong, but I often find that they have a very protracted recovery. And I do not know what the reason is, but I'm therefore much more inclined to do a dermal fasciectomy in the first place, because a very important the characteristics of a dermal fasciectomy, I feel, is that it seems to bring some peace in the hands. I very often, after a normal limited fasciectomy, see that there develops a sausage-like scar under the skin in the first months after treatment, and then I often think, did I remove all tissue or did I forget something? But that is quite normal. But if you remove the skin, you don't see that. So therefore, and especially in the cases where I struggle the most, I usually try to be a bit more aggressive and remove the skin too.
Okay, so would you do that for anyone who's diabetic, or only if you think they got skin involvement?
I would explain to them that I struggle, and I would give them the choice. I'm a big believer in shared decision making, and I very often send them away and ask them to think it all over and come back a few weeks later. So I find it really very important that the patient is involved and that we embark on that difficult road together.
Yeah. I think that's very sound advice. We've got a question from Keith Denkler. Your thoughts on capsulotomy? So I think joint release is probably meaning here, and digit widget. So for those of you who don't know, that's a form of external fixator that you can use pre-op to try and straighten out difficult PIP joints before you do a fasciectomy or dermofasciectomy. Paul.
Yeah, I'm sorry that I did not completely match the brief, because I did not talk a lot about the PIP release. So thank you, Keith, for this question. I remember that I spent some time with you and was even allowed to stay at your home. I really appreciated that. And I learned a lot from your approach to Dupuytren. I have become very hesitant to be aggressive to the PIP joint. I've done that. I've placed K-wires to try and maintain what I had achieved, and then I removed the K-wires, and immediately the contracture was back. So I do not know how to handle them. Sometimes I often make a little hole in the tendon sheath to start with, and if the PIP joint does not give way at all, I may be tempted to try and release the check reins and even release part of the collateral ligaments. But I'm hesitant, because when you turn your back, the scar tissue formation will start, and I don't see in the long run that I get much benefit of it. And there's been a study of Breed and Smith where they showed that the gentle passive manipulation gave the same results as the surgical capsulolysis. So that strengthened my thought to be not too aggressive. And as far as the Digit Widget is concerned, that is an American brand that is not available in Europe. I know that Gus McGrouter, he designed his own Digit Widget consisting of two 2mm K wires and just some elastic bands. And he said that that worked well for him. I don't have any experience with that because I'm always afraid that I get pin tract infects and that I make it worse. So I always tell my patient the MCP joint will usually be released and can be overextended after the procedure. The PIP joint may keep some contracture, but I'm sure that it will not bother you too much.
Okay. Jesper Nordenskjold wants to know, do you splits after surgery?
Your sound is not very clear, Dominic, so I missed that question, sorry.
Sorry, do you use splints after surgery? Splinting?
Yes, I do. Although I realize that there is no evidence for standard splinting, but I usually use it as a way to give the patient as much attention as possible, because hand therapists have more time for the patient than we do. They see them sometimes twice or 3 times a week, and they can talk to them, they can do wound care, and they often apply a splint. If I ask for a splint, I prefer a volar splint, because I think it's better to push than to pull on a remaining contracture. But there's an illusion that by splinting you can further correct the contracture, I believe.
Okay, we've got another couple of questions on post-op care. So one from Sandra Klein asking, is continuous passive motion beneficial post-op? And another one from Pat Wald saying, what do you consider to be a good hand therapist?
Well, the first question, I don't have any experience with it. It used to be quite fashionable a number of years ago, but it I don't know why, but it completely was lost. Charlie, and would you like to say something, Charlie?
There was a study that looked at CPM after Dupuytren and found no added benefit.
Okay. And regarding how to find a good hand therapist, that is difficult. A good hand therapist or real hand therapist have had a special education following their physiotherapy or educational therapy training tree, but I do not know how that is organized in other countries. I know that in my hospital I have a good hand therapist and they have their own network. So very often I refer the patients to my own hand therapist and ask them to refer them to a colleague, to one of their colleagues. And if they come from far away, then I know that there's a few hospitals, or at least every hospital where there is plastic surgery usually have hand therapists. So I refer them to the hand therapy service in one of the hospitals.
Yeah, and I think if you're in a country where you're looking for your own hand therapist and paying privately for that, probably looking for accreditation from a national organization such as the American Association of Hand Therapists or the equivalent organizations in the different countries in Europe or Australasia, that's the way to go. We've got a similar question. How do you vet a competent hand surgeon? Difficult question.
Yeah, that is a very difficult one. I don't have a clue. I know there are people who advertise themselves as being the best. I'm too humble for that. Usually the word spreads, and yeah, I have the luxury now that people come from all over the country for my service, and I'm very happy because Dupuytren is almost the only thing that I do apart from facial palsy, which is a bit of a funny combination, but that is how my practice evolved.
Yeah, I think, again, look for someone who's accredited by a professional organization such as the British Society for Surgery of the Hand or the American Society for Surgery of the Hand again. Charlie, do you have an American perspective on that?
On finding a surgeon, the best resource is talking with a scrub tech or a scrub nurse. That's usually more accurate than even talking with other surgeons. So the other is to ask a surgeon who they would go to. Yeah.
Unfortunately, patients don't usually have an option to go and talk to a scrub nurse. But
there's also there's a Yelp for healthcare providers called Health Grades in the States anyway, that gives patient reviews for what they're worth, and that that's always worth poking through.
Okay, back to some more surgical questions. Or Charlie, do you want to go next?
I just had one question, Paul, in terms of categories of patients. The patient who shows up with fairly normal skin and hypermobile MCP joints and isolated PIP contractures. Any tips in your planning or your post-op care? Or
for me, it depends very much if I can feel the cords very well, and if they are well discernible, then I would embark on a minimally invasive treatment, which is needle for me, because collagenase has never been on the market in the Netherlands. So I used it 50 times a day after I had to stop. And I think as far as the post-op regime is, I think that such a patient may benefit from a splint, and maybe have to splint it in a protective position, because apparently the MCP is not a problem, but the PIP is. But the PIP joints, as you know better than I do, are more difficult to correct with needle fasciotomy. So I always tell my patient, well, I'm going to try, but if I don't succeed, we have to take a more aggressive treatment, which is limited fascictomy. And when the skin is involved, then for me it's dermal.
Thanks.
Thank you. So we had a question from Hein to Linden asking about attenuation of the central slip in long-standing PIP joint disease.
Absolutely. Yeah, that is.
Yeah, tell us
Sorry.
what you do.
Yeah, that is probably one of the reasons why there's a sort of a memory of flexion after you have released the PIP joint. But I must confess that I haven't reached the stage where I do an immediate correction of that. So I'd rather keep it as it is, and the patient may remain with some flexion contracture, and then going in and trying to shorten it or plicate it or whatever, and get an extra possibility of achieving a functional deficit, a flexion deficit, because that is always my worry. Also, patients come in with a flexion contracture of any sort, and you usually straighten them out. But sometimes you do it so well that they can't flex anymore. And if the patient remains with a lack of flexion, that may be much more of a disability than an extension deficit. So I'm very hesitant to go in and do something to the mid slip. What do you do, the two of you, Charlie? Dominic?
I am extremely conservative at the PIP joint beyond excising all of the Dupuytrens. So I found, as you said, that you cause stiffness, and the patients complain about lack of flexion more than they complain about some residual extension deficit.
I agree entirely. Ruins a golf game.
Yeah.
Or, I mean, the ulnar-sided fingers, so your little finger and your ring finger are most functional in flexion, gripping a hammer or lifting a suitcase or a shopping bag. You use them in flexion. So the loss of the ability to flex them is actually much more disabling. And as you rightly said, we all know it affects that side of the hand more commonly, doesn't it? So, David Hunter Smith would like to know whether you have any thoughts regarding either PNF or collagenase upstaging the disease in those patients who you described who get an early recurrence. Does it make fasciectomy harder when you have to come and do fasciectomy later on?
And as far as my experience is, needle fasciectomy does not. As I said before, I don't have enough experience with collagenase to be able to advise. I've heard from some people who have done a lot of collagenase that, especially in the first year after collagenase, it may be a disaster to operate, and thereafter it seems to settle down and become less difficult to do fasciectomy. So for me, after needle, I don't look upon this problem. I really look upon needle as a way to get a feel of what sort of a patient that I have under my hands, and to see how it responds to treatment in general. And if as in that woman of 70, if it comes back really quickly, then I know, okay, this is a more aggressive case. The next time when it comes back so quickly, when 2 months is obviously a very, very short period until recurrence, then I switch to surgery and to a more aggressive treatment, depending on how much the skin is affected.
Okay, we've got a question from Michael Leopold. Have you found any patients developing Raynaud's after surgery?
Absolutely. Luckily, not very often, but I absolutely see them. I think my last case was one of my colleagues of the pediatrics department who ran in quite a serious Raynaud disease or CRPS. No, sorry. Raynaud's is something different. Raynaud's obviously is that you disturb the vascularity. That I do not know if that can be caused by treatment, but I meant CRPS. Sorry, I confused it.
So I think what we do see definitely, and I think the more you ask patients, the more you'll see it, is cold intolerance, which may not be Raynaud's specifically, so that finger turning white and then turning purple and blue at the end. Yeah. But I think lots of patients do find post-operatively some pain, particularly in the cold. And that Jeremy Rodriguez did a study where he looked at longer term outcomes following surgery and following more minimally invasive procedures, and found, I think it was a 7% rate of that at about 5 years, if memory serves properly. So yeah, I think that's definitely a problem that our patients have, and maybe that's another argument for more minimally invasive techniques as well. Any tips and tricks for skin grafting? Jesper Norgenskjold would like to know.
Yeah, I'm very glad that you ask. So I find it really important to remove the skin from mid-lateral line to mid-lateral line. So don't put in a patch. If you have a small piece of skin, you really have to go from one side of the finger to the other side. The glabrous skin has to be removed. I've had one case where I did that from the beginning of the procedure, and I ended up with a totally white finger. And since I already had excised the skin, I had to amputate that finger much more proximal than I had hoped for. So now I always start with my longitudinal incision, and then I try to release as much as possible. Then I release the tourniquet and check what the situation is, and then when the finger pinks up nicely, then I excise the skin. So I always release my tourniquet. I do know that some people don't release the tourniquet, but for me, that's an essential step, because I don't want any hematoma under my graft. When I do a limited fasciectomy, I don't release the tourniquet before closure, but as I said, I leave the wound open at the level of the transfer ligament of the palmar aponeurosis, so that that the hematoma can drain, and I see them back one day after the procedure. In dermal fascictomy, I release the tourniquet, I do hemostasis, I harvest the graft, I apply it, and I don't make any holes in my skin graft, because that again is another trigger can be a trigger for scar release, and the small hole very often very quickly fills up with serum that dries out, and so it is a misunderstanding that offers you good drainage. You need a much bigger hole to get good drainage. Mm-hmm. So I apply the skin graft, suture it in, then I take a big syringe, 20 cc syringe with saline, and I wash the wound bed out for a number of times until I really get clear fluid spurting out on all sides of the graft, and I'm really convinced that every single erythrocyte is out. And then I start applying pressure, and I don't release the pressure until the plaster is on, because that is how I end. I do a yellow net, so a paraffin gauze on top of the skin graft. Then I do a moist gauze on top of that. That moist gauze will dry out. It will in itself become some sort of a plaster. And then I apply a few dry gauzes, and then a plaster of Paris, which I leave in place for 10 days in a straight position. And after 10 days, I remove it, and then I usually have, in almost all cases, I have full graft take, and then I send them to the hand therapy to start exercising and for a night splint. That is my technique.
Great, thank you. That's a good amount of detail. George Chen would like to know about your post-op rehab approach in terms of, we talked about splint already, but then exercises, you sort of touched on that. You say you wait 10 days after a skin graft. Is it exactly different? I presume it's different after a limited fasciectomy.
Yeah, after limited, if I send them to the hand therapist, I like to get them there as soon as possible. And I always tell them, you can start exercising in the bandage, which is a bulky soft bandage. I usually see them back one day after surgery, as I said, to check for an hematoma. And if there's no hematoma, they get a smaller bandage, and they can start practicing. And then the hand therapist takes over, and they instruct the patients to not to overdo it. That is also important, because in the early phase, you don't want to get too much edema. If you get too much edema, then that may in itself cause more fibrosis out. So that's the idea.
And final question from Keith Denkler, again, going back to PNF. We did cover this a couple of weeks ago, but I think it's fair game because you mentioned it quite a bit in your talk. He's been releasing Cleland's and Grayson's with subcision from PNF and the transverse retinacular ligament if there are PIP joint contractures. We saw Gary Pess a couple of weeks ago being very brave around the PIP joint. Have you done that, Paul?
Yes, I learned a lot from Keith when I visited him a number of years ago, and I learned the term subcision from him. And I apply that. So for me, subcision is the release of the skin from the cord. And I also I release the Graysons and Cleland. And Charlie has written a beautiful paper about PNF that was published in 2011 in the Journal of Hand. And I would like to urge everybody to look that up and read it, because it gives you so many excellent tips to do a PNF. As far as the release of the transverse ligament that Keith also alluded to, yeah, I sometimes try that. I'm not as successful as I would like, and not as successful as Gary showed 2 weeks ago in releasing PIP joints. And I always tell my patients, sometimes it's a lucky shot. I had somebody this week who came with quite a severe contracture, and I was just lucky to be able to release it. But that sometimes it works, and sometimes it doesn't. Sometimes the nerve starts to trouble you, and the patient says, "Yeah, I have these electric shocks," and then you have to stop, because then I get afraid. And so far, I have not divided any nerves that I'm aware of.
Yeah,
Yeah.
touch wood. Absolutely. So
Yeah.
one final request. It's not a question, but Jesper Norgenskjold would love you to make an instructional video on how you do skin grafting in Dupuytren, Paul. So we'll leave that with you.
Thank
We're
you.
gonna go to our sponsors for their short video now, and then when we come back, we will have the first of the 3 papers.